Greetings and welcome to today's On With Life webinar on treatment options for managing depression, anxiety, and emotional lability following stroke. My name is Dave Clark. I'll be your host for today's event. Our presenter today is Lindsay Vox-Eldridge, clinical counselor at On With Life. Lindsay received her bachelor's degree in psychology with a minor in biology from the University of Iowa, and she completed her master's degree in clinical psychology from the University of Utah with an emphasis on neuropsychology. Lindsay has been serving brain injury survivors for 9 years and has been working at On With Life for 6 years, where she provides counseling services to inpatient persons served and their families. Lindsay will be leading us through the rest of today's event as our featured presenter. So Lindsay, over to you.
All right. Welcome, everybody. I'm Lindsay. As the title suggests, today we'll be talking about treatment options for managing depression, anxiety, and emotional lability following stroke. I do want to make one important, just quick clarification before we start. I'll be talking about emotional lability rather than emotional ability, so apologies if you did receive materials with that typo. All right, we'll go ahead and get started. So in terms of objectives for the webinar today, first we're going to kind of review those most common psychological changes following stroke. I will explain their kind of potential impact on the rehabilitation process and quality of life for individuals. And then we'll also discuss treatment options. So kind of what do we do about this? Knowing that these things can be quite common, what do we do and how do we intervene? And both will focus on what research says and also information from kind of clinical observations and clinical practice. So depression is one of, if not the most common psychological change that occurs for individuals after stroke. An estimated 30% of individuals will develop depression after their stroke. However, I have also seen studies suggesting even somewhat higher prevalence rates than that. Survivors are most likely to develop depression within the first year post-stroke. However, risk still kind of remains high, relatively speaking, even in years beyond that first one. Although post-stroke depression is well documented, post-stroke anxiety, on the other hand, in various forms, has been much less kind of heavily researched. A variety of studies suggest that roughly 20% or more of stroke survivors will develop heightened and problematic anxiety. Rates for individual anxiety disorders can often vary quite widely across studies, but there are several studies that I've included the findings of in this slide here. Kind of suffice to say 20% is likely to be an underestimation of the actual likelihood of developing some form of anxiety disorder following stroke. All right, the third most common or quite prevalent psychological change that people experience after stroke and that we're going to talk about today is emotional lability, which is defined by difficulty controlling emotional responses that results in periods of laughter and or crying that may occur at inappropriate times and be kind of stimulus incongruent. So for example, laughing when something sad happens. Or these periods of emotional lability may occur kind of out of the blue without any emotionally relevant stimulus present at all. So for example, laughing when nothing funny has happened, then the individual themselves does not find anything funny in that given situation. For the individuals that experience this, their emotional display is often kind of exaggerated, sometimes quite dramatically exaggerated beyond what they would have experienced pre-injury in response to that same stimulus. And many times people have identifiable triggers for their lability, with family being kind of the most relevant and common trigger for individuals. Arrival and departure of family members seems to be kind of a biggie, but sometimes even the mention of family or even thoughts about family is enough to kind of trigger an episode of lability for them. And then, of course, for other individuals, they really don't have identifiable triggers, and it's kind of quite variable what moves them to an episode. clinically, with stroke survivors, I certainly see labile tearfulness more frequently than I do laughter. We do see laughter, but again, tearfulness much more common, I find. And also emotional lability, just so you're kind of aware, emotional lability can also be referred to as something called pseudobulbar affect, or PBA. PBA is exclusive to laughter and crying. However, on occasion, you will also see kind of like a wider definition of emotional lability that people use as well, that includes frustration and anger, kind of difficulty managing and being easily moved to frustration and anger. So now on a kind of prevalence for emotional lability, research suggests that roughly 20% of stroke survivors experience emotional lability, with rates varying kind of widely across various studies. However, self-report by survivors suggests that rates are in fact much higher than that 20%, with 53% of survivors reporting PBA symptoms on a lability scale that was included as part of a National Stroke Association survey in 2010. And 40% of those individuals that said, yes, I experience emotional lability, indicated that those episodes were severe enough to interfere with social activities, including kind of time spent with family and friends. So certainly getting, you know, it's pronounced enough that they were getting in the way of kind of quality of life and socialization. I would say that 53% is probably closer to the prevalence that I see clinically. It just is quite common for people to experience at least some amount of emotional lability for a period of time after their stroke. I do often see this fade over time for folks. The episodes do tend to be kind of more pronounced earlier on in their after injury, and dissipate over kind of the course of several weeks or several months. However, for a small percentage of folks, the lability does seem to kind of persist and hang on a bit over time. Again, not common. Again, normal trend is that it fades, but for a select few, it can be quite problematic and more chronic in nature. So that covers kind of the three most common psychological changes that arise following stroke. However, there are certainly more that we unfortunately just won't have time to cover in this talk today. All right, in terms of impact, these psychological changes that can occur after stroke oftentimes do have a fairly significant, sometimes very significant impact on the quality of life, adjustment, and rehabilitation success of the individual. So they really can kind of derail rehabilitation at times, and I've certainly seen that in practice. And they can end up kind of resulting in poor outcomes functionally, physically, and cognitively for the individual, unfortunately. These psychological issues can also impede optimal kind of adjustment and coping, which is already in and of itself kind of a fairly, I mean, not fairly, it is a difficult process, even with very sound and even ideal mental health and great pre-injury coping strategies, et cetera. You know, the task of adjusting to your life looking dramatically different in an instant like that is already quite trying. So if you add any of these psychological changes on top of it, it can become a lot more difficult. People can experience physical consequences as well when dealing with these psychological changes. So for example, these psych issues may affect their sleep. It may result in increased fatigue. They may have more difficulty managing their medical status and other health conditions, of which they likely have several comorbid health conditions that they're tasked with having to kind of keep on top of and manage, especially once they're out of an inpatient care setting. And also relationships can be compromised as a result of these psychological changes. So for example, depression and anxiety can increase social isolation, leading to decreased closeness and social support. Emotional lability can be difficult for loved ones and certainly in the people in the community to understand, and can make kind of forming new relationships more difficult if the displayed lability is quite pronounced. We had an instance years ago in which a young mother indicated that her lability for laughter had made parenting her young children quite difficult. So, you know, the children would do something that they weren't supposed to, which oftentimes was still funny or humorous. And that's something that as a parent you have to inhibit, right? That response, that it's maybe a little bit funny, even though you want to discourage it. And for her, she really couldn't inhibit that laughter. And so she would laugh in response, even though she wanted to discipline them or discourage the behavior. And it was confusing for the kids. It was instead reinforcing for them. So, you know, just got in the way, obviously, of her relationships and what she was trying to do as a mom. So it really behooves us as medical professionals to do as good a job as we can managing these conditions. And if we think about kind of like what well-rounded rehabilitation and long-term services looks like for an individual after a stroke, it should hopefully include kind of proper and ongoing management of mental health issues for individuals. Okay, so now knowing that these things are quite common and that they can interfere, what do we do about them? What are our treatment options? Okay, pharmacologically, in terms of interventions for depression, I should first mention that we do fairly frequently see antidepressants used prophylactically now after stroke. So people are being placed on them very early in the rehab process, sometimes while the person is still at a rather low level of responsiveness, and certainly before they can kind of like in theory become depressed. I have seen also this practice, I will say, increase over the 6 years that I've been here at On With Life. Just more and more people are coming to us straight from the hospital, again, at sometimes rather low levels of responsiveness, already on an antidepressant, sometimes for several weeks or, you know, even a month or more. And that practice is really done for two reasons. One, there have been studies suggesting that early administration of antidepressants may be associated with improved recovery outcomes, maybe particularly motor recovery, irrespective of the mood benefits that are provided by the antidepressant. So this idea that being on an antidepressant is resulting in something that's neurologically beneficial and beneficial in a kind of healing and recovery sense for the brain, regardless of the benefits that they produce for mood or in treating depression. And then the second reason that this is more commonly done and has increased over time is this idea that we know well now that depression is quite common after stroke, and we also know well the negative impact or impacts that this can have on rehab outcome and quality of life for the individual. So taking an antidepressant even before the person is or could become depressed may essentially prevent that potential derailing of the rehab and recovery process that depression would have resulted in potentially for the person. So kind of like if we can nip that in the bud and prevent, the rails from going out or the cart from going off the track, and kind of give people optimally, what we'd hope for them, then why not do it? So there is some research supporting this idea that depression rates are lower, in fact, for individuals that received an antidepressant prophylactically. And if we're talking about folks that have already become depressed, there is quite strong evidence that use of antidepressants to treat that depression results in improved rehabilitation progress and improved functional outcomes. With only about 3 to 6 months of proper antidepressant treatment, those depressed individuals achieved kind of comparable recovery to entirely non-depressed survivors. So there are several antidepressants within kind of different classes that have research supporting their use in the treatment of post-stroke depression, including but not limited to heterocyclic antidepressants, namely nortriptyline, that being the most common of those, and SSRIs with pretty good evidence for Celexa, kind of some conflicting evidence of the efficacy also for Prozac, some studies showing that yes, in fact, it does seem to really help, and other studies not as strongly supporting that notion for Prozac specifically. But again, new studies are coming out all the time. There's likely to be more antidepressants beyond those that I list here. Also, there's some indication that Ritalin may be beneficial in treating post-stroke depression. And finally, some evidence that reboxetine, which is a medication I'm not clinically as familiar with, but it's a norepinephrine reuptake inhibitor and is marketed as an antidepressant, but has off-label uses as well, that may also be effective in treatment of post-stroke depression. In terms of psychotherapeutic interventions for post-stroke depression, there's actually conflicting evidence on the effectiveness of psychotherapy in this kind of general sense. It's a bit surprising that the findings are as mixed as they are about how much and whether or not psychotherapy really helps. However, given the body of research supporting the use of psychotherapy, particularly cognitive behavioral therapy, in depressed individuals without stroke, it is certainly reasonable to encourage psychotherapy, at least as an adjunct to medication. And I'll tell you that I still use cognitive behavioral therapy, or CBT, interventions in my inpatient counseling work with individuals. And I feel that I have personally seen benefit from utilizing those tools. However, I do feel that cognitive behavioral therapy interventions aren't appropriate for every person served or patient. And even when they are, there can still be limitations to their application within the stroke population that may make them less effective than in the general population. I'd say namely, cognitive deficits that are occurring for people after stroke, which can sometimes be a big limitator to how beneficial those interventions might be. And in addition, I think also there's this phenomenon that, kind of mood is not, in my work here, because I'm dealing with inpatient person served, mood is often not really the primary focus, frankly, of their inpatient stay. They are coming to us often directly from the hospital. They're early on after injury, and they're trying to just adjust to and kind of make sense of a ton of stuff and a dramatic amount of life change. And they have a lot on their plate. And there's a lot expected of them in terms of their therapies, and they're kept quite busy. And I find that sometimes people aren't quite as invested in the therapeutic work or the psychotherapeutic work as, say, someone who comes to you like in a private practice setting, for example, saying, hey, look, the biggest issue I'm dealing with and the reason I'm coming to see you is because I'm depressed, I'm down all the time, and I don't know what to do about it. So for them, they may be a bit more invested, just in that work in a general sense. But in terms of some of the research support that is out there for the use of psychotherapy for post-stroke depression, in a randomized control trial, there was a CBT-based intervention that was modified for individuals with aphasia called the CALM program. And that was shown to be more effective in reducing depressive symptoms than usual or typical care alone. In another study, psychosocial behavioral therapy intervention completed along with antidepressant medication was found to be more effective than taking antidepressants alone. And I will just kind of add in that anecdotally, I have also seen benefits from things like behavioral activation and social support, both kind of within and outside the context of formal group therapy, in addition to other things. But even though, again, not strong, super strong research support saying yes, everyone should have, anecdotally, I feel like there's certainly benefits. There are also some kind of alternative interventions for treating post-stroke depression. Some of these interventions show some kind of emerging evidence of their efficacy, but for further research is also needed. The evidence for repetitive transcranial magnetic stimulation, or RTMS, may have kind of the most promising research backing of these listed here, with 2 randomized control trials showing significant reduction in depressive symptoms after a stroke. So kind of neat and a cool kind of emerging area there. Outside of stroke, within the general population, light therapy actually has a fair amount of research support for treating both seasonal affective disorders, which we hear about more often, and also treating non-seasonal depression. However, there are very few studies to support this intervention in treating post-stroke depression. There's just one kind of randomized control trial that I came across, and it was being used as an adjunct to an antidepressant, and wasn't a super robust finding, but again, good research base within general population. So be curious to see more, maybe studies in the future to see if that would be a benefit. For the other interventions that are listed there, evidence is quite limited or pretty mixed, and further research is definitely needed to determine effectiveness in treating depression after stroke. At the very end there, I list PET therapy, and I will admit to you, I have not read any reports about this intervention for depression in stroke survivors, but I will just tell you that anecdotally, most people really do kind of truly light up around animals, and it seems to lift their day in a way that most humans can't. So we're very fortunate here at On With Life in that we have a therapy dog named Lolo who is regularly here. And I'll just say that, if you have the opportunity to incorporate animals at all into your rehab setting or medical setting, that go for it, do it. Help staff too, I think. Okay. When we're talking about treatment of depression after stroke, there are absolutely kind of unique factors that you should be keeping in mind and modifications to treatment that you may need to make. First and foremost is cognitive and communication deficits. These can really complicate the psychological assessment process and the mood assessment process. So I'm often in this position of kind of like watching and waiting, waiting to see if and when communication and cognition improve enough that mood assessment becomes appropriate and possible for the individual. That's very heavily dependent on having a consistent yes-no method. So you really have to have that in order to be able to complete any kind of psychological assessment with the individual. But once you have that consistent and accurate yes-no method, that I would say that opens up the doors dramatically in terms of what I can do with people. It gives me a huge window into how they're feeling, and just allows for a lot more to be done kind of psychologically and in terms of counseling. I will tell you that we're not picky at all about how that yes-no method presents. So I've done mood assessment with individuals using eye blinks and using differentiating types of toe taps and thumbs up and down and head nods and shakes, and even individuals that have no ability to speak but are able to do choice making with their fingers, for example. So a lot can be gained from people that maybe at like face value you would think are not able or not appropriate yet to complete psychological assessment. And sometimes it's really much more about the person's inability to kind of, that they understand quite well what's going on, and certainly understand your questions, but aren't yet able to make their responses known. So again, once they finally are at that stage, that just allows for a lot more. Now, then the validity of psychological assessment when cognitive deficits are still present ends up being a fairly kind of gray area. And oftentimes this happens very frequently, right? In stroke population, likely people have some amount of cognitive deficit. And so, kind of trying to determine the validity of your assessment, given that that some form of cognitive deficit still remains, becomes, very much kind of this clinical judgment. Even sometimes with fairly notable cognitive deficits, so, sometimes fairly significant short-term memory deficits, impaired awareness of deficits, for example, assessment, I believe, and I would argue, can still yield some pretty helpful information. So, for example, someone's self-report of the presence and absence of symptoms may be quite telling, while their estimate of something like symptom frequency might be rather unreliable still, given those short-term memory deficits or poor temporal orientation or things like that. So I am usually of this mindset that once I and speech therapy feel like, yes, we have a consistent yes-no method, it is in my best interest and the best interest of the person served for me to go ahead and meet with them. But I go in knowing that depending on the extent of those lingering cognitive deficits, I may have to take portions of their report with kind of a grain of salt. There may be parts that I feel quite confident in, and there may be others that I don't. So once you've obtained an accurate assessment, then you have to think about kind of how those cognitive and communication deficits may impact treatment options. So there may be all kinds of things and all kinds of interventions that you think would be beneficial for the individual, but their deficits may mean that you only get to do a fraction of those things. Whenever possible, try to kind of look at how can I tailor this intervention? How can I alter those materials, make it more simplified? If I can't do the entire intervention, what parts can I take? And then know too that some of that practice is absolutely trial and error. Just going in and attempting things and seeing how it goes. It's hard to know sometimes in advance how well and how much the individual is going to be able to take from some of those interventions, even after tailoring. Just as kind of an example of this and the idea of kind of modification and how you go about tailoring, is a question of, how do you do psychotherapy, for example, with somebody who has significant expressive aphasia, where they really only have command of 2 words or 4 phrases or something like that? Can you still do psychotherapy with someone like that? Well, if their receptive language is still pretty high level, if they understand fairly well what you're saying, then I would argue, yes, you absolutely can still do psychotherapy with them. But you need to be prepared for that to look quite different than kind of traditional or standard psychotherapy. Already just in that situation, the balance of who will be talking more is going to be dramatically flip-flopped, obviously. So giving those people an opportunity to tell you yes, no, as much as possible within the context of those counseling sessions is really important. Doing lots of stating and then checking back with them to see how accurate that description is that you gave. How well does that describe what they're trying to say if they had, or what they would have said if they had full command of their language, for example. And then also realizing too, when you're doing too much kind of talking at the person in that given scenario, right? When it's just become too much, okay. And best to kind of wrap up or move on, or be done for the day at least. Lastly, it's very important to distinguish depression from emotional lability. So those two things are very distinct. Just because a person is often tearful does not mean that they are depressed. So ideally, that assessment is done by a trained mental health professional. That said, I realize that that's also not possible in all settings. And in that case, getting as much training as possible is really key so that you do a good job of differentiating, is this lability versus is this depression? Or could there be both? Okay. So now on to anxiety. Having anxiety in addition to depression leads to greater impairment post-stroke for individuals. Survivors with comorbid anxiety and depression had higher levels of impairment in activities of daily living. They had more cognitive impairments, and they had fewer social ties than those with depression alone. So having both means poor outcomes, more impairment overall. There is fairly limited research on the treatment of depression, the treatment of anxiety. within stroke populations, unlike depression, which is heavily researched. But I did manage to find a Cochrane database review that did include a few useful studies, which found that mean anxiety was significantly lower in those receiving Boost Bar compared to standard care. Another study that found that mean anxiety scores were 58% lower for those who were assigned to a group taking Paxil, and 71% lower for those who were assigned to a group that received both Paxil and psychotherapy in a group format. So, and both of these groups were compared to like standard care. So some indication there that an SSRI and an SSRI plus psychotherapy in this particular example were helpful in treating anxiety. In the absence of strong research evidence in the treatment of post-stroke anxiety, it is logical to go ahead and kind of utilize anxiety interventions that are well supported within the general population. So, however, like we talked about with depression, in doing so, there are certainly factors that you're going to want to keep in mind and modifications that you may very well need to make. First off, early confusion can really result in this notably heightened anxiety that fades really without specialized intervention as the individual kind of continues to recover over time, particularly as cognition improves, which often kind of results in this more full recognition and understanding of circumstances and familiarity with surroundings that allows for, reassurance, comfort, and just sort of getting the bigger picture in a way that brings down anxiety and distress, again, kind of without intervention. So you have to kind of ask yourself, if it's very early on after injury, is some of this overall distress and heightened anxiety that I'm seeing just purely a product of the injury and due to high levels of confusion still and disorientation? And do we need to, provide as much reassurance as we can for the individual and potentially medication? But that some of this is likely to just kind of dissipate with further recovery. For lingering cognitive deficits, though, it is extremely important to adapt psychotherapeutic interventions. So, for example, cognitive behavioral therapy has a great body of literature supporting its use in the treatment of anxiety disorders within the general population. However, some of those concepts may be quite challenging for people to grasp after stroke sometimes. It may require kind of simplified explanation or a great deal of repetition of those concepts. For example, CBT homework may not get completed. Oftentimes that's part of cognitive behavioral therapy, is this idea of homework and doing work in the off time outside of those therapy sessions. And, you may see people really struggle with that when you assign it, and not because they aren't invested, but because they have memory deficits and they have difficulty with organization and initiation and follow through and all of those kinds of things. Even medication management of anxiety symptoms can sometimes be impacted by cognition. For example, someone may not do a great job of recognizing their early signs of anxiety or their typical kind of patterns in the typical patterns in their own presentation of their anxiety, and therefore won't effectively self-administer an as-needed medication, for example, to assist in managing symptoms. I can think of a previous person served that we had for whom that was true. And it was, at the time it was surprising to me because she was quite high level, honestly. She was one of those individuals that you worked with and you thought, does she really even have much in the way of cognitive deficits? She just a lot more physical impairment after her stroke, but cognitively, again, high level. And even for her, it really took, over time, in a short amount of time, it became quite clear that she was consistently having panic attacks at this late afternoon period of time. And even, within about 30 minutes day to day, around this 4 o'clock time. And it took me really pointing that out to her and saying, why don't we try to, you have the ability to request your as needed Xanax. Why don't we try to go ahead and get ahead of that and maybe take it at 3:30? or 3, you know, and see if we can kind of head that off of the past to some degree. So can affect kind of, yeah, overall medication management and how properly people are doing that too. You want to think about kind of similar tailoring when it comes to communication deficits, and we've talked a little bit about that in the context of depression. When we're talking about post-stroke anxiety, it's important to realize that the uncertainty of the person's medical status or the potential for a repeat stroke or cardiovascular event may be a significant source of their anxiety, or at least a contributor to their anxiety. Clinically, I have certainly seen that, particularly for people who had panic attacks or post-traumatic stress symptoms after their stroke. Often the fear of having another stroke and or kind of the reliving of their stroke experience, if they did in fact remember that, was kind of the thing that was causing their anxiety issues. So just something to be aware of there. To best address post-stroke, to best address post-stroke anxiety, you may need to actually attend sessions. And especially if you're working in an inpatient or outpatient rehab setting, you have a really unique opportunity to see the anxiety in action, which rarely ever happens right in private practice. And so, you know, being able to guide them through use of strategies and the things you're talking about in counseling sessions, being able to guide them through that in the moment while they're in fact experiencing that anxiety and are exposed oftentimes to the stimulus that's causing them anxiety is just so much more useful than talking about it kind of theoretically. So it's absolutely something to consider. All right, and again, there are those few studies that I mentioned previously, but the evidence is fairly limited. So I will talk in this slide really about kind of interventions that I clinically have found to be beneficial for people struggling with anxiety after stroke. Medication has certainly been a common and very important treatment for anxiety in our setting. And that includes treatment with SSRIs, benzodiazepines, and Buspar, which is an anxiolytic medication that works primarily on serotonin and dopamine. So those are kind of like the typical ones that we have used, but at least within our setting. In terms of psychotherapeutic interventions, like I discussed with depression, I do use cognitive behavioral therapy techniques and have found those to be beneficial for some individuals. Again, you know, being kind of selective about who you think that that's most appropriate for and tailoring those interventions as you need to. Of course, utilizing and teaching relaxation techniques like mindfulness, meditation, progressive muscle relaxation, imagery, deep breathing, an assortment of different things. I find that for most individuals, it's best to kind of try a smattering of those, try a variety of them to see really what the individual says they feel like they respond best to. It's just everyone seems to be kind of unique and different in terms of what they find most effective for relaxation strategies for them. Next is the idea of examining triggers, which is very important I think in good anxiety management within this population. And it's in part really important to determine whether or not you should be avoiding the triggers, whether those are triggers to be avoided or to, in fact, not be avoided. This really depends on overall level of responsiveness and cognitive status of the individual. You know, early on after stroke, some people are very, very easily overstimulated, and exposure to things that seem really mundane to us, like, you know, light and sound, movement, touch, stuff like that, may be causing a lot of anxiety for the individual. And in these cases, we likely should try to avoid some of those triggers that are distressing to the individual, with the knowledge that this is likely a product of purely their brain injury and an early phase of recovery, and it's going to likely get better. And that there isn't really utility or need for us to kind of cause undue stress to the individual by kind of forcefully exposing them to these things if we can avoid it. All of those obviously can't be avoided. You know, people are still going to have to be moved, but there's certainly modifications that we can make. However, on the other on the other hand, flip side of the coin, if as the person does continue to get better and as they progress and as they're moving out of that early stage and improving, they still have lingering anxiety in response to certain triggers. And if they are very kind of selectively attempting to avoid those, those triggers, particularly when the avoidance interferes with their rehabilitation, then we absolutely need to identify those triggers, have everyone be on the same page about what they are, discuss them, build strategies around them, and continue to, in fact, expose them, kind of consciously expose them to those things. That brings me to the next kind of therapeutic intervention that's listed there, which is formal exposure therapy, which may be warranted in some cases, kind of specific cases. For example, in managing something like obsessive compulsive disorder after stroke. I can think of a woman that we had who a while back here that had a 30-year history of severe OCD pre-injury. Post-injury, she was quite confused at first, and as a result, the OCD was more manageable for her. And for her loved ones too. The better that she got, though, not surprisingly, the more the OCD tendencies kind of started to surface. And it was very important from the get-go that we continue to expose her to things that she would have tended to avoid, certainly pre-injury she would have avoided, would not have been able to do at all, and prevent her, or at least quickly kind of move her past compulsion-based behaviors when they surfaced. And doing that built in some early exposure that she wasn't as aware of, and that she absolutely would not have tolerated if she was higher level cognitively. And it kind of set the precedent for what rehab and what her days were going to look like. So as she continued to progress, she kind of knew, even though I don't like doing these things, even though these things are distressing to me, I'm going to be expected to do them anyway, kind of as part of my rehab. She came to expect it, and in a way that was beneficial for her in continuing to address the OCD behaviors. Finally, a great deal can be gained, I think, from group therapy. Simply talking with other individuals on a regular basis who truly understand what the survivor is going through and can offer insights about how they cope with similar problems. And that goes for treatment of anxiety as well as other psychological issues. And I think just promotes, good adjustment and coping in a general sense, even for people that don't have any diagnosed psychological issues after stroke. So those are just a few that personally I have used and found beneficial. Of course, that list is not exhaustive, though. Now on to emotional lability. So in terms of treatment options, we'll start first with pharmacological interventions, and I'll really mention kind of two things. So there is a new medication or newer medication that has been on the market for a while now called Nuedexta, which is an FDA-approved treatment for emotional lability, or pseudobulbar affect, whichever term you want to use. I have certainly seen this medication be effective in decreasing episodes of emotional lability, both in terms of like frequency and severity. It's been beneficial. As an aside, we do sometimes run into difficulty actually with insurance approving this medication. So there's been cases in which we've wanted to utilize it and have not been able to, unfortunately. But when we have had approval and been able to use it, I have often seen it be beneficial for treating emotional lability, and especially more pronounced emotional lability that doesn't follow that typical course of fading over time for people, or is just quite problematic and getting in the way of things. Second bullet listed there, there is evidence suggesting the treatment with antidepressants after stroke, both SSRIs and tricyclic antidepressants can be associated with a reduction in emotional lability as well. Right. although these don't necessarily have a strong basis in research, there are some therapeutic interventions that can be beneficial in addressing emotional lability. And these really come kind of more from clinical practice and reading and that kind of, just try it and you'll see sort of mentality. And I have certainly seen a great deal of benefit from doing these things. So the first listed there is to provide survivors and their loved ones with psychoeducation on what the heck emotional lability is and how it can present. Especially labile tearfulness can often be mistaken for depression in individuals. It's this idea, I think I mentioned before, that if they're crying all the time, they must be depressed. However, emotional lability is very much distinct from depression. People can have depression, they can have emotional lability, they can have both, or they can have neither. So first, it's important to kind of educate about what lability is. And I think there's often a fair amount of relief for survivors and caregivers that comes from just better understanding. This is a real thing. It's that it happens to a lot of individuals. They're not alone in it. There's a term for it. And it's because of my stroke, and that it will likely continue to fade over time for me. And if it doesn't, we have things we can try to utilize. So I find a lot of relief often for individuals in that psychoeducation piece. Then clinicians should both utilize and teach proper response strategies for lability, essentially educating themselves, fellow staff members, the survivor, and their loved ones on what to do when the person experiences an episode of lability. As human beings, when someone displays emotion with us, we naturally tend to kind of match the emotional response of the other individual. When they laugh, we start to smile and possibly laugh too. When someone starts crying, we tend to adopt kind of an empathetic facial expression and begin to comfort them. However, with emotional lability, this is precisely the wrong approach. Generally, you want to keep your facial expressions neutral and keep your verbal responses pretty matter of fact, pretty direct. Bullets 2 through 4 there are all kind of related concepts. This idea that you want to, as soon as you can, when someone becomes labile, change the topic to something that's non-emotional. It tells the brain, okay, there's nothing more emotional here in the environment. I can kind of go ahead and switch off that emotional switch, so to speak. As much as you can, trying to then divert and or distract and kind of funnel the person's attention to something else is beneficial. Doing that and getting them on to moving their attention onto something else hopefully will diminish the likelihood that lability comes back quickly. Sometimes you're left in a position where you just have to kind of ignore it and pretend like it's not happening. A lot of these strategies can at first blush sound a bit insensitive, right? Again, if somebody is crying in front of you and you're going to keep a neutral face, be matter of fact in your responses, change the topic to something else and distract them and ignore their emotional response, it sounds insensitive. And so it can be hard for new staff sometimes to get used to doing these things, but they really are in fact the best intervention. And I've many a time been in a session with somebody, especially because what I'm talking with people about is more emotional in nature, of course, given what I do, that it causes an episode of lability, and people have sat right in front of me and literally been sobbing, and I will continue to ask them questions with a straight face, and you'll just see this individual going from wailing to all of a sudden saying, oh yeah, actually I am starting to do some walking and physical therapy, and just it's like a light switch turning off, so this idea that you just kind of keep going and keep moving and don't give it a lot of credence, don't give it a lot of attention. Oftentimes attention to the labile response kind of feeds that labile response. So seems weird, but it's really the best. These things are really kind of the best interventions. Sometimes when the lability is more pronounced, you may need to, if it's you, remove yourself, or if it's your loved one, remove your loved one from the lability causing stimulus. sometimes that's not possible, of course, but especially in like higher stakes situations, or again, if very severe, you may actually want to go ahead and try to just get some distance from the stimulus itself. This last one that's listed here is, again, very much just something I've clinically found for me in practice, and it really depends very much on the individual and on their given presentation of lability, whether or not this might yield any benefit for you. But on occasion, I've been able to kind of divert what would have been an episode of tearfulness, labile tearfulness, into laughter, which is a much more comfortable and kind of situationally appropriate, usually, emotion for them to kind of display. So instances in which I've seen someone very much kind of starting to get that labile tearfulness, and I've been able to quickly make a joke and kind of divert that into a laugh between us both, and then moving them on with the session. Again, it doesn't work every time. Isn't the right intervention for everybody, but on occasion. If emotional lability is less severe, I will say that it is sometimes okay to give kind of a very brief acknowledgement or comfort and then move on to the strategies. But in more severe cases, you really want to skip even that brief 5-second acknowledgement of the emotion with a kind face or something like that. If it's more pronounced, you don't even want to give that. You just want to move on to these strategies listed here. So, all right, and that kind of does it for me. Thank you all so much. I'm going to turn it back over to Dave for some questions.
Thank you so much, Lindsay. And indeed, it is now time to transition to the Q&A segment of today's webinar. And in fact, we have several really good topical questions that have already been submitted. So to get us started, let's go to a question from Jay. Lindsay, Jay wants to know what happens after a person leaves an inpatient setting. Who addresses these mental health issues?
Sure. Yeah, absolutely. That's a great question. It really kind of depends on the individual and the situation who ends up addressing them, I think. For some individuals, when they leave, I can speak obviously, more from my own inpatient perspective. When they leave inpatient, for some individuals, it's absolutely necessary and appropriate that me or nursing staff be setting up psychiatry and or psychotherapy referrals for them. And that we have those things in place even before they leave. Just there's been enough going on that they're going to absolutely need that kind of close monitoring. There are other people for whom, though, they may have had psychological changes and psychological issues in their stay here, and we've addressed them while they're here. They're doing rather well. Medications haven't had to be tweaked in quite some time. Symptoms are pretty well managed, and they or I or both of us kind of agree that they may not really need to continue to, they maybe don't need much of my services anymore anyway in an inpatient setting, and they don't need to continue to see someone in the community necessarily. So for those individuals, I say, absolutely, if something changes or worsens, then here's where you go, and then it certainly becomes important to get them the adequate services that they need. I will also say that people's kind of primary care physicians and other doctors that they're seeing on a follow-up basis, like neurologists, for example, that they may be having some follow-ups with down the road, are really in this unique position to be able to continue to monitor mood. And I hope that they are. I hope that they're asking those questions, and that they're, doing screenings periodically, because it's, you've got the individual kind of periodically in your office, and you have this chance to catch hopefully some early things that are changing and refer them as needed. Again, because people might do quite well in this inpatient or even an outpatient environment. It's highly supported. It's very structured. Has lots of built-in support. But being home or being in a longer-term setting may be much harder to cope with. And again, that risk for depression, especially, still remains high much beyond that first year. So just it's something that you want to really, really continue to watch and monitor for.
All right, next up, let's go to Peggy. Do you ever see depression resolve on its own without treatment?
I do, yes. I would say, that's not probably the norm, but I do see that on occasion. There may be, individuals for whom they, in earlier on in their rehabilitation process, they endorse symptoms of depression. And for whatever reason, interventions are not appropriate, or they choose not to have interventions for whatever reason. And just with kind of continued time and recovery, those mood symptoms kind of dissipate, and the person just kind of gets better. And when I see them, a couple months down the road, or even sometimes, several weeks down the road, they're really doing quite well, and they're no longer endorsing those symptoms, for example. I have seen that. And what's to contribute to that or cause that? I think to some degree, it may be that there's early kind of chemical changes that are contributing to those more pronounced mood symptoms. And just as people's brains continue to recover, those levels, rebound in a way that allows for improved kind of mood for the individual. And then I think probably to some degree it's due to continued kind of adjustment of that individual over time and over the course of their rehab too, that they get used to us, they learn what to expect of the rehab process, they have a chance to begin to see themselves progress, that they develop some expectations for like what is rehabilitation and recovery after a stroke going to look like, utilize their social support more fully, get to know other people that are in their shoes, and that all these things, just kind of help in moving them past some of that early depression. I will say too that it's one thing to kind of watch and wait in an inpatient setting. It's much less risky, frankly, to give the person, if they either aren't appropriate for or don't want interventions and services for that depression. I still have access to them every day. And I still, I'm able to check in regularly with therapists and nursing staff and family, and them as to how they're doing. And if things were to worsen, I could very quickly intervene and could have repeated conversations and come back to some of these things and, look again at what about some of these interventions. So it's much less risky to do in an inpatient setting. It's probably a different story for you to just say, oh, let's just see how it goes on an outpatient basis. Because if you're a primary care doc, for example, and that individual endorses depressive symptoms and nothing is done about it, they may never come back to you, and so then who knows what happens and whether or not the person gets, whether things worsen and the person is without proper intervention and support.
All right, and I think we have time for one last question. Lindsay, this one is from Phil. Phil wants to know, how much does emotional lability interfere with rehabilitation?
It certainly can, I guess, is the short answer. For some individuals, it's, it may be quite present and you even see it a fair amount, but the episodes are rather brief, and it just, for whatever reason, doesn't seem to interfere. They move past it rather quickly, or it doesn't take much in the way of strategies to move them past it. And so it doesn't interfere much. But then there's, again, I kind of said, there's a subset of people for whom it's more pronounced and it hangs on longer. And there's been certainly times, not frequent, but certainly times where I've seen more pronounced emotional lability interfere with rehabilitation, really interfering with what they can do in terms of participation, interfering with sessions have to be stopped, that kind of thing. In those instances, you really want to kind of aggressively be making sure that you're utilizing all interventions available to you. Have we looked at medication? can we tweak medication? Can we try a different one? That becomes a really important piece, the medication management. And then also, is all staff across the board consistently utilizing those strategies? Are they knowledgeable about the strategies, and are they in fact doing them to try to help the person move past those episodes? And even sometimes when you feel like, gosh, I'm using every tool in my toolbox and I'm doing all the things I can think of, that lability is, unfortunately, sometimes for a select few people, may still be quite pronounced and still continue to interfere to some degree with sessions. And may lead to like discontinuation of therapeutic sessions and things like that. And you kind of know, this is still kind of getting in the way. And you continue working as much as you can, but you're also, keeping your fingers crossed that just with some additional time and healing that helps to diminish the lability further in those cases, in those kind of stubborn cases.
All right. Well, that is just about all the time we have. Again, thank you very much, Lindsay. And thank you very much to all of you for being with us today. That does conclude today's webinar. Have a great day.